Oh, do you want to wait?
How long is that going to be? Yeah. We can wait a minute. I hope.
Are we live? We're live. Why don't you start?
Hi, and welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
Good afternoon. I'm Mike Berkowitz, Electronic Editor for JAMA and the JAMA Network.
All right, so first paper today, we are talking about the end-of-life care received by physicians compared with non-physicians by Dr. Hannah Wunsch and colleagues, including senior author Rob Fowler. Dr. Fowler, welcome.
All right, thanks very much for inviting us.
Sure, so please tell our viewers, tell us about yourself, tell us about what you did here in the paper.
Well, so I'm a Canadian critical care physician, and I work here in Toronto at Sunnybrook Hospital. And I've had an interest in end-of-life care, certainly as it pertains to patients that are critically ill for a long time. And my colleague that you mentioned, Hannah Wunsch, is an American-born and trained critical care physician. And we've been able to recruit her up to Canada the last few years, and we had the opportunity to work on this study together, something that was interesting to both of us.
Great. And it looks like you looked at basically the end-of-life care that physicians got compared to non-physicians. Tell us what you did and what you found.
Well, that's right. I was thinking earlier, if there was ever a study that I might have predicted the outcome of in one direction, this might have been it. Clinically, I think a lot of physicians have the sense that we may approach care at the end of life a little bit differently from a lot of our patients. And certainly in the ICU, a very sort of technology-laden part of the hospital, there are times when we think some of the work that we do is perhaps less helpful in particular periods of life. And both Hannah and I and others have thought that looking at this from the perspective of what would physicians do might sort of inform what physicians perceive as best practice in both their case, but also perhaps for the patients that we treat. And so we looked at this question in the Ontario context, which is a population that has relatively good health administrative data, and so tracked really from birth onwards in a way that you can get a sense as to every interaction with the acute healthcare system and, in fact, the chronic healthcare system as well, and then somewhat uniquely able to identify who are physicians in the system and who are not physicians. And that set up this study that allowed us to look at the particular question of end-of-life care.
And before you go on and tell us what the findings were, what was the research question then? If you can clarify that, and what would you have predicted the findings would be?
Yeah, so our hypothesis, and it was stated up front in the paper, was that physicians on average would opt for measures of less aggressive care at the end of life. And by that, I mean things like the location of death being in an intensive care unit, or perhaps some of the elements of end-of-life care that might involve critical care, so mechanical ventilation and certain procedures. We thought up front, based upon maybe our own beliefs, our own perceptions of what we might choose, that physicians would generally opt for much less of that. So our clear upfront hypothesis is that physicians would opt for and receive less aggressive markers of end-of-life care.
Yeah, so you looked at this administrative data from 2004 through 2015, found about 2,500 docs, and then matched 3-to-1, so about 7,500 non-physicians who were matched with them for socioeconomics, comorbidities, et cetera, and looked at what they found. And what I found most fascinating is it basically looked like a U-shaped curve. Physicians seemed to get more intense care, some more ICU care. Patients with chemo patients with cancer, got some more chemotherapy. But then also more, say, death at home and some other markers of less invasive care. So basically more invasive and less invasive care by the docs. Does that sound about right?
Yeah, that's pretty insightful. When we looked at this over a long period of time, we were initially sort of struck by how similar, frankly, the care was at the end of life for both groups, and we were a bit shocked that what we had thought ahead of time didn't pan out. Yet looking a little bit more closely, just as you've said, it did seem like there was a bit of a nuance to the findings, and the nuance is in that U shape, and that it seems as though on average physicians might opt at times for a little bit more aggressive care, including admissions to ICU at the end of life, but similarly opt for more palliative care. And in thinking about this, I can imagine in my own circumstance, family members and friends compared to physicians, et cetera, that maybe that is the case, that physicians do sometimes opt for maybe aggressive care, but then at a point perhaps pull back and maybe address end of life in a different way that might involve more palliative care and home care.
But that's not a temporal relationship, because you found that as many physicians experience their end of life in an ICU setting as non-physicians. Is that a fair assessment of the findings? So it's not like they tried it out and then decided they wanted to go home and die. I just wanted to make that clear, at least as I read your data.
Yeah, there's a portion of that. So in the location of death, that doesn't look at temporal trends at all. That would be where, in fact, you died, and there wasn't any difference in location of death. Yet, looking at the 6 months leading to death, we did see that there was both an opting for more ICU, but on the other hand, a bit more palliative care, and the coexistence of that. And what wasn't presented in the paper a little bit, and maybe will be in the future, is that sort of temporal relationship, where in fact some people might, if you want, try out or at least sort of approach care a bit more aggressively, but then pull back at a different time.
And one of the things I found interesting is the physicians had fewer ED visits in the last 6 months of life. Difference about 5%, so about 1 in 20, which is pretty decent as far as a difference. And that reminded me of a paper we published a few months ago in JAMA Network Open about patients with cancer and their ED visits, and how a lot of the ED visits were about symptoms, not necessarily progression to disease, but just patients getting admitted for symptoms like nausea, vomiting, pain, shortness of breath, and also just the amount of uncertainty that we deal with patients in the ED, and that physicians would theoretically or plausibly seem to have more information or more access to medications for symptoms, and have less of a reason to go to see another doctor about their symptoms when they know what's going on, perhaps.
Yeah, there were, and in addition to that paper, there were a couple of others that JAMA published about 3 years back that addressed a similar question about location of death and care at the end of life, showing, I would say, a little bit less aggressive care at the end of life, but marginally so. And all the factors that you mentioned around that potential for formal and informal access to care, or access to even opinions of colleagues, etc., maybe differences in socioeconomic status. I thought that might underlie some of this. And in the Ontario context, many of those factors still are at play, but maybe a little bit less so in that all of the population has complete coverage for most all inpatient care, and a very similar degree of coverage for outpatient care. And so theoretically, there might be a little bit of a different driver in terms of socioeconomics, but those other sort of softer things are perhaps still at play, and maybe they were involved in our study as well.
I assume a lot of the action in your data set is in or surrounding Toronto, but I'm wondering whether you have a look or have a glimpse or impressions about what we would consider here urban versus rural differences in these patterns, which is kind of a subgroup analysis, may not be fair, goes beyond what you report in the paper, but just wondering what your instincts were. Any differences there, or nothing important to look at?
Yeah, we thought as well that there could be differences based upon urban and rural gradient, and to some degree there's some potential interaction with socioeconomic status there. Potentially in some rural areas there might be a little bit less access to some forms of care. Maybe a sense that folks in rural areas may perhaps opt for less hospital care, but it's pretty complex in the Canadian context, in that sometimes there's relatively more acute care beds in rural areas than there are long-term care beds or hospice or palliative care beds. And so the direction could conceivably go either way based upon those sort of inputs. And I would say ultimately we found there wasn't a big gradient one way or the other in an urban and rural context.
One of the reasons I'm asking, I'm spinning off lots of explanations for the findings in my mind. One is that, if you're in a complex medical center, you want your colleagues to take care of you. You put your lives in their hands, for example. That may be different in settings. The other thing that I'm a little worried about is that the healthcare complex is like a conveyor belt, and once you touch it, you just get sucked on in to kind of more aggressive care, even kind of quote unquote when you know better as a physician. So I'm obviously you can't read those mechanisms or meanings out of these data, but I'm just trying to kind of tease out in my own mind what it all means.
Yeah, no, that's such a I think such an important point, and we see that all the time. And it's in the Canadian context where we did this study. One of the things about the Canadian healthcare system is that I would say it's sort of grown up as fairly narrow and deep, and that there's very deep coverage for patients, but that coverage is often focused for acute care and certainly hospital settings. And we have a relative lack of options for care outside of the hospital. So much less hospice-based care and palliative care than exists in the United States, and including the Medicare option to opt, if you want, for more hospice and palliative care. We don't exactly have that in Canada, and that's a failing of the system, and one that people are working on, but certainly something that we experience here.
You mentioned earlier some of the specific procedures. One of the things that gets a lot of discussion are things like, I'd say politely, less high value procedures toward the end of life, things that are invasive like trachs and feeding tubes. I found it interesting that there was no difference in CPR rates or very similar rates of tracheostomy, but surgical feeding tubes were higher among the physicians. Any thoughts there, or any other specific elements at the end of life there?
Well, it's like one more element that I was completely surprised by. And I just thought that some of these things that were very technical, very sort of procedural at the end of life, we weren't going to see. And lo and behold, we did. I mean, one of the things I'm trying to think about, well, why is it that our perception is different from what we have seen in this data? And again, we were struck by it. And in trying to say, well, is there something different about our perception and this data? I suppose one thing to bring up, and you guys probably would, is that the folks that are the subjects, if you want, in this data, are people that are on average are about 80 to 82 years of age, and so they represent a particular sort of birth cohort on average that is frankly different from the birth cohort of the folks that conceived and were doing the study by about sort of 30 to 40 years. And it's quite possible that our perceptions of what our colleagues, rank and file folks now at a very different average age might want is in fact quite different from the findings that we see here that are, again, representing folks that are octogenarians. And in physicians are not. And it may be that that things have changed over the last sort of generation and a half, and we will see differences in the future, but we don't see it now.
Great. Well, I think that's a great way to finish. Really interesting paper. Always love when there's surprises, and that's why we do the science in the first place. So thanks for joining us.
Yeah, love the paper, and thanks for submitting it to JEMA Network Open.
Thanks very much.
Take care. What's up next?
Great. Next up, this is a fun paper I'm excited about because I'm a nerd.
Me too, and I'm a nerd too, I guess.
Association of Emergency Department-Based Intensive Care Unit with Survival and Inpatient Intensive Care Unit Admissions from Kyle Gunnarsson and colleagues from the University of Michigan.
Right. So this is an ICU in an emergency department adjoining an emergency department. What does that mean?
Yeah. So University of Michigan started what they call an ED ICU, or they call it the Emergency Critical Care Center, or EC3.
Yes.
Basically an ICU that's run by the emergency department, essentially separate from the rest of the hospital's ICUs, that they can send their critical patients to. And it's really fascinating. There's all the talk, and I mean, all the docs on Twitter love critical care, love resuscitation. So this is a topic that's near and dear to lots of our hearts.
And so the research question they were asking, which I was a little surprised by, was does this EC3 ICU unit reduce mortality overall among ED patients, and does it reduce admissions to the ICU? Right. So those were the two primary outcomes. But I was a little unclear about a few things. Sure. But why don't you describe how they set up the study?
Sure. So basic stuff. It's a simple before and after study. Basically, I think they use the essentially quality improvement data. So from 2012 to 2017, they looked at all the ED visits, and as you said, measured overall mortality before and after the implementation of the ED-ICU, looking at all the ED patients. So basically, one of the questions would be, one of the fears would be, first off, are ED docs who work in the ED-ICU just providing bad critical care and therefore killing patients essentially. Another fear would be, is it a big opportunity cost, and that pouring resources into the ED-ICU would take resources away from the rest of the patients. And basically, they've had good news that everybody in the ED live longer after they put in the ICU.
Right.
And as you alluded to before, with the last paper, this is all observational data. We can't get into causality, but that won't stop us.
Right. But so here's my question.
Yep.
Why do you have an ICU adjoining your ED? So
Sure.
and I have two answers, but I
Sure.
want to hear your answer. One is
Oh.
because you want to admit a patient to the ICU and there are no beds available.
Mm-hmm.
So you need to kind of administer the higher level of care than you could in an ED
Right.
bay or a resuscitation bay for a prolonged period of time until the bed opens up, and then you take the patient up.
Right.
That's one thing. The other thing is because this patient's maybe on the edge between needing intensive care, maybe needing a regular unit bed, or maybe being able to go home. So you want to observe them, give them higher level of monitoring, and then kind of make that disposition decision.
Yeah.
So, right? I mean, but the first one wouldn't affect mortality. The second one
Or
might.
would it? Because basically, I think a lot of it, especially with a lot of critical care patients, there's still a lot of boarding in the ED. A lot of patients who are admitted to the hospital who are waiting downstairs for their bed and their team to be ready upstairs.
Right.
So what's the alternative, really? As you said, this isn't about patients who were being withheld from an ICU. They're patients who would have otherwise probably just been waiting for the ICU and being taken care of by the ED team with a kind of standard emergency department resources and attention or lack thereof that they would get at that point. So if the alternative is just kind of sitting in a standard ED bed, not getting dedicated critical care or getting, I don't know, what critical care could be mustered by the team that's taking care of the rest of the emergency department, it certainly seems plausible that having a dedicated area with dedicated resources and attention to give to these patients would improve outcomes.
So why wouldn't the comparison be mortality of those patients in the EC3 that made it to the ICU after the EC3 was implemented, compared to patients who made it into the ED and then were admitted to the ICU?
Yeah.
That seems to be the comparison rather than looking at mortality for all ED patients, because I wasn't even clear what proportion of ED patients made it into the EC3 and whether you would expect to see a reduction in mortality for every patient who made it into the ED, if that makes sense.
That does make sense. It's a good question. I'm going to buy myself some time to think of an answer. Welcome some of our new viewers. Claudio Lobo-1, Dr. Mamakai, and Hyung Cho, who's we've talked about a couple of his embedded commentaries here.
Awesome.
So welcome, Doc.
Thanks for joining us.
Thanks. So I think there's a couple different responses. First, as a research question or just as a methods, it's hard to identify the exact patients you're comparing for apples to apples comparisons.
I admit that.
So also a lot of the patients who are going to go to the ED-ICU are by definition not going to go to the ICU. So if for me, two of the good examples are patients in DKA who oftentimes are obviously critically ill up front, need a ton of resources, but can turn around very quickly.
Right.
I've certainly worked in places where the culture was, well, we're not going to have a bed for hours and hours anyway. Why don't you just keep them here, make them better in the ED, and then send them to a medicine floor?
Right.
But if they can go to the ED-ICU, get better care, that might be better for them. The other thing is, or like an upper GI bleed, patients who are either very, very ill or at risk for being very, very ill, and they just need to be monitored, maybe sedated for an EGD, and then if everything's okay, they wake up and go home.
Right.
So there's a couple different situations where it would be hard to find, especially in even in clinical data, to find patients who are apples to apples comparisons for that. And again, I think a lot of the comparison too is what happens to the rest of the emergency department patients. Not only are there patients who require critical care in the emergency department, but there are a lot of other patients. So what happens to everybody in the emergency department, I think, is a useful metric to make sure that there's not spillover effects that are bad.
So I'm totally on board with that. But the thing that they also didn't tell me is how staffing changed.
Sure. Yep.
Like whether they actually poured more resources into the total ED in order to support the EC3.
Right. And that's actually there's an invited commentary by, Eric Hess is one of the authors, I forget the others, and I apologize, and basically makes a really good point that a lot of the questions are about how do you make the dollars work for this, and points out that, some of it's critical care billing, which you're able to do better in an ED-ICU than in a general ED. And another part of it is a big part of their financial model is foundation money. They basically got money,
Right.
Charity money.
The
to pay for
Don
this.
Massey Foundation, you know how he made his money? He
Yeah.
had Cadillac dealerships all through southeastern Michigan.
Interesting.
Yeah.
Michigan loves cars.
Yes, they do.
And so a lot of this is clearly infusion of resources. So I also think this is the way I see this. A paper like this is really this is mostly a description of what they did and some safety checks to look. We didn't kill people doing this.
Right.
And by the way, the numbers are actually more optimistic or better than we would have thought. I mean, honestly, I found the outcome data more impressive than I thought it would have been, and well above a bar that I think would make it acceptable. They also there's a ton of secondary outcomes they measured, other sorts of safety checks, 24-hour admission or 24-hour mortality, upgrades to ICU from general medicine floors, and some other things like that that are in the paper and supplemental appendix, that it's not just these two primary outcomes. There's a whole bunch of things they checked that all looked pretty good.
Right. I'll also point out that they're good about saying that there was like 12 to 15 or 17% missing data for mortality.
Mm-hmm.
And as far as I can tell, I didn't go deep into the supplements, but
Right.
they didn't do any analyses that account for missing data,
Sure.
what those outcomes might be, and that could, in theory, modify their favorable conclusion about mortality. But I want to zoom out for a second and just kind of tell you an anecdote and see what your reaction is. I worked in an ED setting,
Mm-hmm.
not a true board-certified ED setting, and I fought unsuccessfully for a few years to get the rounding in the ICUs to happen much earlier in the
Mm-hmm.
morning, so that as the ED began to fill up by 11 a.m. or noon, the beds would be open, the dispositions would have been made earlier in the day, and we wouldn't have the need to observe and care for these patients
Yep.
in the ED as much. And obviously, that never happened. The attendings met with their teams at around 10, finished around noon, but beds only began to open up at 5 or 6 p.m. And I don't know whether that's the same dynamic where you are.
The more things change, it's it's. I think a lot of hospitals have gotten better at it. I think one of the downsides of how busy hospitals are now is that at my hospital, a lot of the inpatient services are non-teaching services.
Mm-hmm.
So there aren't those same kind of time constraints of the med student pre-rounds and then the residence round, and then there's a big rounding, and then and then you stop for conference, and then you start just dispelling people.
Right.
But there's still all sorts of reasons why it's hard to get people out early in the morning, and matching resources to patient flow is very tough. I would say one of the reasons I'm optimistic about boarding in emergency departments is that there are so many opportunities for improvement, and that's just one of them. Other things like just discharge. One of some of the low-hanging fruits like discharge. What do they call them? Discharge lounges, where patients who are waiting for non-physician, non-nursing services like a dietitian, like social work, or just simply waiting for their rides to come. Most of the time have to just sit in their inpatient room waiting for those things to happen. But if they had a nice cafeteria area with cards and books and TVs to watch, would seem to make some sense.
We have a new viewer, I think.
Yeah, a couple of viewers. We have Yale Cardiology and Judith Sweeney from Virginia Beach.
Welcome, guys. And I think I'll say one more thing, because the commentator on this piece in the journal talks about cost, the cost of implementing. But you probably know this better than I. The cost of a formal admission is really huge, and you actually save a huge amount of dollars by not admitting them and calling them an observation patient. Right. So I don't quite know where the billing and reimbursement is there yet.
Right.
But you actually get a huge gain by saying you're not actually admitting somebody formally. So there's kind of book kind of on the margin savings there for these units. So I'm bullish on them. I actually am in favor of this thing. I'm just not entirely sure I believe the mortality data, because it doesn't have face validity to me. But I hope it's true.
Right. Yeah. And for me, I think I obviously am generally pretty positive on this, but I think that my most negative way to describe it would be they couldn't get their hospital to admit patients to the ICU, so they built their own ICU.
Right.
And
that's a sign of dysfunction.
Right. Absolutely. And we all know that academic centers have lots of dysfunction and lots of opportunities for improvement.
But you're optimistic.
Yeah. But I'm optimistic, and a lot of it's like step down units. It's like observation units. It's why are the options being at home, being in the ED, being in the hospital, or being in the ICU? There's lots of middle grounds like step down or like short inpatient stays or short observation stays or ED obs. And this is kind of one way to essentially right-size care for critical patients. Again, there are critical patients. There's a 22-year-old with DKA from type 1 diabetes because they had trouble getting their insulin and they just need a few hours of attention versus a nursing home patient with multilobar pneumonia and multi-system organ failure are going to be very, very different ICU stays. So if this is one way to better right-size care and resources for those patients, and this is really important, making sure that the resources are available and applied to other patients as well, which again, I think is why it's important to look at the overall mortality here, or why it's good to look at the overall mortality, making sure that, when I have that patient who's really, really sick in my ED waiting for that ICU bed, all the attention I'm giving to them is attention I'm not giving to other patients.
Right, and there was an interesting study, and this is ages ago, and I probably shouldn't be quoting it because I don't remember, that looked at celebrity ED visits and the mortality of ED patients when celebrities visited. Because basically the thought was the same thing. All the attention goes to this one single patient that's high profile. Do other patients suffer? And I think the answer was no in that particular study. Anyways.
All right.
Okay.
But also, just a friendly reminder, don't look up celebrities when they're visiting your ED or you'll be fired.
That's right. Don't go into their medical records.
All right.
That's exactly right.
So that's it, of course. Send our comments, etc. This is lastly once again, the Association of Emergency Department-Based Intensive Care Unit with Survival and Inpatient Intensive Care Unit Admissions by Gunnarsson. And we are going to move on to our table of contents rundown.
Let's do that.
All right, so make sure I'm on the page. All right, first up, this one's interesting. Normal weight central obesity with all-cause and cause-specific mortality among postmenopausal women. So they looked at using Women's Health Initiative data, 150,000 women who started the study in 1993 through 1998, followed them through 2017, so lots and lots of years of data, 13,000 cardiovascular deaths, 12,000 cancer deaths. And basically looked at a couple different permutations of BMI categories and then central obesity. So essentially, what's your waist circumference? And essentially found that the two conditions that were the highest or had the highest association with mortality were obesity plus central obesity or obesity and normal weight. So being normal weight overall, so normal BMI, having a large waist is as bad for you in this study as being obese with central obesity with a hazard ratio of 1.3.
Right. So obesity is usually defined or has been defined as a BMI greater than 24?
25? Yeah, 25.
Okay.
Or no, 25 to 30 is overweight. Over 30 is obese, right?
Yes. That is correct.
Right.
So these are women with normal BMI and large waist circumferences. And so this was surprising to a lot of people. I'm not sure it's that surprising to me. Certainly, BMI is an awkward measure. It's become an important measure of obesity because it works. It can consistently, on an epidemiologic population basis, is associated with adverse cardiovascular and other health outcomes. But it is not perfect, and this shows that.
Yeah, exactly. I agree. I mean, you're smarter than many people about BMI. The BMI is useful as a screen for obesity in individual patients, and is very useful for using big administrative data or big survey data with thousands and thousands of patients because all you need is height and weight. But we know in general that people who are overweight paradoxically tend to do better, possibly because BMI doesn't capture things like heavier muscle mass and being more in weight. Plus, it's probably just not a simple linear curve, and there's all sorts of different body types, et cetera. And this is hinting towards waist circumference is helpful in kind of teasing that out. And it probably wouldn't be that hard to also start putting waist circumference in big databases.
Right. And there's another related concept. This has nothing to do with a visceral adiposity, particularly, I think, in Asian populations where they have normal BMI, but have a lot of visceral adipose. And that also, as metabolically active tissue, contributes to adverse metabolic and cardiovascular outcomes.
Right. Switching gears to this is an interesting study where they looked at four internal medicine teaching departments in the Netherlands, 2016 2018, compared them to 19 control hospitals, did this big, intense intervention on reducing unnecessary ordering of tests, using awareness, education, and feedback, increased supervision, changes in the order entry system, et cetera, and found over that time period, the control hospitals had an increase in testing of 2.4%, which is interesting because just generally in the whole mix of things, there's a lot of attention towards unnecessary testing, but of course, at the flip side, populations are getting sicker, et cetera. But an 11% decrease in tests among the intervention group. So basically found if you intervene, there's some space to decrease unnecessary tests.
Right. And totally generically, typically when you scale back on those interventions, things return back to normal. Can you give an example of a couple unnecessary tests?
I don't remember off the top of my head. I think it's things like daily labs, screening chest x-rays, stuff like that. Low-hanging fruit stuff.
Okay. As I looked for it, it was in the supplement, but it was a little bit unclear. They mentioned chromosomal testing. I wasn't sure when I was going to order that. I can clearly imagine what they are, plain x-rays for back pain and things of that sort. But
Yep. Well, this is exactly. So good stuff. But anyway, I think with interventions, we're able to teach people to order less unnecessary tests.
And there's a lot of medical overuse.
There is.
What's next?
All right, next up, so back to physical fitness. Trends in adherence to the physical activity guidelines for Americans for aerobic activity and time spent on sedentary behavior. So they used NHANES, big national survey data. They compared the 2007-2008 period to the 2015 to 2016 period, about 27,000 people in the study. The good news is that as there was no loss of ground in physical activity, so similar rates, 63% versus 65%, which is about the same in big groups like this. The bad news is that, well, first of all, that a loss of ground or a lack of loss of ground is considered good news to me is very bad news. And second is that sedentary behavior is up about an hour. So a decade ago, sedentary behavior was 5.7 hours a day, and now it's 6.4 hours a day of people just sitting and not doing anything. And the more I sit in the office, the more I think about that.
It's a lot of mobile devices and screens. JAMA published the physical activity guidelines in November of 2018, and the same crack team that's bringing you this live broadcast produced this awesome video summarizing it. So check that out on JAMA.com. Just do a search for physical activity guidelines 2018.
And just to be clear, I was not part of that crack team.
Yeah.
So, so when he says crack team, he doesn't include me. All right. Next up, this is an interesting one. So Association of Racial Bias with Burnout Among Resident Physicians. These authors use survey data from 3,400 second and third year residents. Compared basically three different things. The standard Maslach burnout inventory, a survey about docs being burned out. Basically, anytime you see burnout in any sort of scientific or lay article, this is what they're talking about for this survey. And then two different measures of racism. One, the feeling thermometer, so what they call explicit racism. So basically, how do you feel against African Americans? And then the implicit association test, which we talked about a few months ago, I believe, where it's one of those things where they do they show you, like, say, different pictures of people of different races and different terms that are good or bad, and how quickly you can react to them.
I just want to be clear. So the physicians who are endorsing burnout symptoms or not are the ones whose racism is being assessed, or are we assessing their exposure or perceptions of experiences of racism?
So good question. So the former. It is that basically what they found is that the doctors who had burnout were more likely to have both explicit racist views on their feeling thermometer, and also more likely to have more biased findings on the implicit association test.
So that sounds to me like a good finding. That is that the patients who are being burnt out and close to leaving practice are the ones who have negative attitudes that could adversely influence a working team and environment, and we would want out of the workforce anyways.
Yeah, although I'm not sure how much burnout leads to actually leaving practice more than just wanting to leave practice.
And,
and of course, in a study like this, there's no real no answers as to which way the calls or arrows work.
Of course.
If you're burned out, does that mean your guard is down and you're more likely to be unable to suppress negative views?
Right.
Or is it that docs who are racist are also the docs who get burnt out? And I would not be surprised if either of those were true or both.
Yeah. Okay.
All right. Next up, this is one you're going to like. So the artificial intelligence algorithms to assess hormonal status from tissue microarrays in patients with breast cancer. I actually am not sure I understood what they did in this study, so let me see.
I'm not sure I can help you.
Okay, good. Go. So they looked at 5,300 breast cancer slides. They used hematoxylin eosin stained images, which I believe are just standard histo slides and normal stuff that pathology departments look at. They looked at traditional testing, so molecular biomarker expression, using histomorphology, immunohistochemistry. So So the normal testing that you do that's kind of advanced with fancy biochem stuff to figure out what subtypes of cancer it is. And then try to use deep learning to just look at the regular plain images, the standard images, and see if it could figure out what the that
Hormonal
histomorphology was, the hormonal status, the
estrogen,
receptor.
progestin, or triple negative. Right.
Without doing that fancy testing, and the deep learning was able to do that pretty accurately.
Okay.
Does that sound right?
That sounds right.
Yeah. So basically, that deep learning may be able to use traditional pathology slides to figure out this kind of fancy biochem stuff without doing the fancy biochem.
Right. So this is another application. We talked about celiac disease, right? We've published about retina images for retinopathy of prematurity as well as diabetic retinopathy. Yet another application. Call for papers in the fall for AI informatics papers, and so this is kind of the fruit of that. All useful, doesn't mean it's ready for prime time.
Yeah. So probably not ready for prime time, but again, good foundational stuff. I think it's also if computers, which are getting, this kind of deep learning stuff is getting cheaper and cheaper and easier to do, and if it can replace more expensive involved types of testing, especially since we had a paper a couple weeks ago about how there's a projected physician shortage in pathologists. So this kind of stuff that might be helpful down the road. All right, last paper we're going to talk about. This is early interventions with birth outcomes and child linear growth in low and middle income countries. They did a Bayesian network meta-analysis of RCTs of all sorts of interventions on how to improve health in pregnancy, childbirth, and what they call the first 1,000 days, which, if I remember from my MPH, is the first 3 years of life, have been very, very important and a big place for intervention in low and middle income countries, because that's when getting the right calories, not having bad diarrhea, kind of getting that foundational growth is very important. Basically, the bottom line is they looked at 300,000 different participants in all these different RCTs. The two things that really shook out was that nutritional interventions are the best, so better than other types of interventions, and also that interventions during pregnancy worked better than interventions on infants and children, which to me, the SNP passes a SNP test as far as, really getting, getting in early to make sure that birth weights are good, to really sustain that growth and not have to make up ground seems to make a lot of sense.
Right. So getting at kind of the earlier theme from the author interview, we spend tens or maybe hundreds of thousands of dollars on complex care, but really the basic interventions for population health are early and simple. Right? And that's where we're going to get the most bang for our buck.
Yeah.
And if children voted, that would happen. But children don't vote, so child health is probably underprivileged in our culture, in our healthcare communities. Thank God for our pediatrician colleagues.
Yes, thank God that they do what they do, so I don't have to.
Okay.
All right, great. Well, thanks for joining us. We will be back standard time Monday, 2 p.m. as usual. Follow us on all the usual social channels, Twitter, Facebook, LinkedIn, Pinterest for the visual abstracts. You can get the audio of the author interviews where we get podcasts, like Apple Podcasts, etc., Stitcher, all those other places, and read these articles and more for free and open access at JAMA@networkopen.com.
Thanks for following. Thanks for watching. We're now releasing new material on Wednesdays at 10 a.m. and on Fridays at 10 a.m. So sign up for our emails and always come to JAMA@networkopen.com. Thanks and see you next week.
Great. Take care.